Hello, everyone. Good evening. It's my pleasure to welcome you to tonight's CCLP Policy Forum on the fight for quality, affordable healthcare. We're so glad you're with us. First, we're going to begin by talking about the simultaneous interpretation options that are available for this event. And I'm going to hand this over to Gilda, who's with us to explain that process. Gilda, go ahead.
Yes, good evening to everybody. I'm just going to be giving some instructions of how to use interpretation services. I will do these announcements first in Spanish, and then I will go back to English to explain everybody what is that you need to do. Las personas que se hayan unido a esta llamada y que hablen español y que quisieran escuchar esta sesión en español, por favor, van a ser... Dentro de unos minutos van a ver un globo terrestre, va a estar en la parte inferior derecha de su pantalla, hacer un clic y elegir español como idioma de preferencia. Si usted estuviera en su teléfono, elija los tres puntitos que están en la parte superior de la pantalla de su teléfono, hacer un clic ahí y después elegir español. For English speakers, if you do not speak Spanish and you would like to listen into English any comment or any question that is done in Spanish, please choose in a few minutes. Once I'm done explaining how to use these services, you're going to see the icon of a globe in the lower side, I would say right-hand side of your computer. And you have to click in there and choose English as your language of preference. If you are in a phone, please go to the three dots that are located in the upper hand side, that is the right-hand side. Click in there and choose English as a language. You will hear the whole presentation in English, but then when somebody is asking a question in Spanish, then you will hear my voice into English. Thank you very much.
Okay, thank you, Gilda. And with that, we're going to turn interpretation on. So you're going to need to click on that globe icon at the bottom of your Zoom screen, as Gilda said, and select the language channel of your choice to hear audio in that language. So go ahead and do that now so that you can continue to listen along. So I'm now speaking in the English channel. You should also hear me being interpreted in the Spanish channel and the ASL channel. Thanks, everybody. And with that, I'm pleased again to welcome you to our event tonight. We're so glad you're with us. We have a tremendous agenda ahead of us, and I just want to cover a logistical detail before we get started. You're going to hear a lot of great information at the start of this event from our presenters and advocates here at CCLP and some of our partners, notably at Colorado Consumer Health Initiative. As the presentation proceeds, you may have comments or questions that you want to make. Go ahead and put those questions in the Q&A box. So similar to the interpretation option, you'll see at the bottom of your screen, but on the left, Q&A option. So you can open that box up and put your questions in there at any time during the event, and we will field those when we get to the audience participation portion. You can also make comments in the chat box, and we will monitor for those, but preferentially we like them in the Q&A box. It's a little bit easier for us to manage, but either way, we'll get you in with your questions, your comments. There's also going to be the opportunity to go ahead and come off of mute during that part of the event if you like. So if you want to do that when we get to that portion, just go ahead and raise your hand, your virtual hand, which is an option in your participant screen, and we will be able to unmute you and you'll be able to actually talk directly into the meeting. So we look forward to that part. But first, we're going to get to our presentation, and to kick us off with an introduction is our new executive director here at CCLP, Lydia McCoy. If you haven't met her, you really should. She's fantastic. And this is her first big CCLP public event. So we're pleased to welcome her and have her give us a tremendous introduction and start to this event. Lydia, take it away.
Thank you so much, Bruce. Appreciate it. I'm Lydia McCoy. I use she, her pronouns, and I am the new executive director of the Colorado Center on Law and Policy. I'm thrilled to be a part of this brilliant team and the amazing work that we all undertake together. This is the third installment of the CCLP policy forums. This one focused on health. And this is really what I want to emphasize to you, is that this is a forum for discussion and sharing. So you're going to be hearing different data and insights that the CCLP team is going to share, things that help inform our work and prioritizing our work as a common understanding of the issue that we're dealing with. But really why we're hosting this event is because we want to hear from you. So as you're hearing the different data and insights and other kind of information that you may have already known or hearing for the first time, think about how this relates to your specific experience, either with your organization, with you personally or within your community, because we're here to have a conversation about these issues and how we can all work together to overcome some of these barriers. So the agenda tonight is the first part. We're going to talk about healthcare costs in Colorado. So who's shouldering a lot of the burden, who is saddled with debt, who's coming out ahead. And then we'll move into component 2, which is healthcare disparities and Medicaid. So really talking to access to care, providing care with dignity and equity, and really grounding that in the humanity of all people. And then we'll open it up for the questions, answers, and discussion, which really is the heart of this event. So please do, as Bruce said, put your questions into either the Q&A box, the chat box, or just write them down somewhere for yourself so that when we get to that Q&A portion, you can come on camera and off mute and share your story or your question yourself. That's really the best case scenario, that we're engaging with you that way, if you're comfortable. And in order to kick it off, I'm going to hand it over to Charlie Kessler on our team, CCLP's policy fellow. Charlie, take it away. Oh, Charlie, you're on mute.
There we go.
Yeah,
Okay.
I mean, that's the perfect start, really, to something like this. Is
right. Hello, everyone. Thanks for taking the time to listen to me. I'm going to be talking about medical debt here in Colorado. So we know that medical debt burdens
Charlie, for some reason, it went on mute again. Like a ghost came in.
There we go. I don't know what happened. Anyway, thanks for letting me know. I'll start over. We got it. So we know that medical debt burdens Coloradans at high rates. Over 700,000 Coloradans have medical debt in collections. The lack of access to public programs and Medicaid specifically increases the rates of medical debt. You'll see in the graph on the slide that regardless of insurance status, people report high rates of medical debt. But looking at the top bar, 62% of people are uninsured, report having medical debt. States that did not participate in the Medicaid expansion that was allowed under the Affordable Care Act have much higher rates of medical debt and at higher amounts than in Colorado. And people who are uninsured are often charged higher prices for the same services as insured patients. Further, underinsurance can also lead to medical debt due to high deductible plans and high out-of-pocket costs. While having health insurance lowers the likelihood that someone will have medical debt, having insurance doesn't necessarily preclude someone from having medical debt. So who is impacted and how? We know that 1 in 8 Coloradans have medical debt in collections. However, we also know that that burden is not carried equally. Due to systemic barriers, some communities have higher rates of medical debt than others. We know that BIPOC individuals as well as LGBTQ+ individuals are much more likely to carry medical debt. This is largely due to systemic discrimination, higher rates of poverty, and a higher likelihood of having health conditions that require more medical attention, among other systemic barriers and issues. The high cost of childbirth also contributes to birthing people having higher rates of medical debt. People who have medical debt are impacted in a myriad ways. 63% of people with medical debt report cutting back on food and other household necessities. Many people end up foregoing or are denied medical care, which can exacerbate health issues. And children who live in homes where someone carries medical debt have worse health outcomes as well. In terms of housing and homelessness, one study found that unhoused people who have any medical debt, no matter how much, spent 2 more years without housing than those without medical debt. So, this, as many of you know, this past legislative session, in coalition with many of our community partners, House Bill 231126 passed, which removed all medical debt from Coloradans' credit reports. The bill went into effect last month, and CCLP and our partner organizations created in-depth guides for people to know their rights, check their credit reports, and how to contact credit reporting agencies to get it removed. Our efforts here in Colorado, combined with continued support from national partners, have led to a major victory. The Consumer Financial Protection Bureau just announced last week they will be making a new rule that will mirror what Colorado has accomplished and remove medical debt from credit reports nationwide. We are extremely excited about this. And now that medical debt has been removed from credit reports, Coloradans will have better access to credit, such as credit cards, mortgages, small business loans, and more. Employment, as some jobs require a credit check, and stable housing because rental credit checks will no longer affect tenancy. This is by no means the ultimate solution to medical debt in Colorado. It is just one piece of the puzzle in tackling this pressing issue. I look forward to hearing from you all as we discuss next steps and innovative solutions to eliminating medical debt. Thank you. And with that, I'm going to pass it to my colleague, Julia Char-Gilbert.
Great, thanks so much, Charlie, and thank you all for being here tonight. As Charlie said, my name is Julia Char-Gilbert. I use she, her, ella, and I am a policy advocate at CCLP. Next slide, please. And today I'm excited to talk with you all about hospitals in Colorado and whether they can afford to do more for our low-income patients. I know that talking about hospitals can sometimes feel rather complicated and confusing because the American healthcare system is very complicated and confusing. So today we're going to tackle this issue, or tackle this topic rather, in sort of 3 simple bite-sized chunks that cover 3 key ideas. So key idea number 1 is that hospitals have made a commitment to serve their communities. Hospitals are an important part of our healthcare system. They are where we turn to when we are sick, or when there's been an accident, or when we're expecting a baby, and we really rely on them to care not only for the rich, but to care for everyone in our communities. This is entirely consistent with how hospitals describe themselves. For example, Common Spirit Health, which is a hospital system that used to be part of Centura, they celebrate the fact on their website that they advocate for those who are poor and vulnerable. Another hospital system in Colorado is Banner Health, and they also, on their website, celebrate the fact that as a nonprofit, they exist to provide healthcare services to the communities that they serve, rather than to generate profits. Indeed, hospitals' responsibility to serve the community is especially true for nonprofit hospitals. Most of the big, powerful hospital systems in Colorado are actually nonprofits, and they have a special arrangement under the law. They don't have to pay any taxes, and in return, they have a legal obligation to give back to the communities that they serve. In other words, as taxpayers, we let them off the hook for paying taxes with the understanding that they will be contributing to the public good as part of their work as healthcare providers. So that begs the question, are Colorado hospitals upholding their end of this bargain? So that brings us to key idea number 2 for tonight. Coloradans are struggling with high healthcare costs, as you just heard in Charlie's presentation. 1 in 9 Coloradans has had trouble paying their medical bills in the past year, and 1 in 8 skipped seeing a doctor for needed care because of cost. As Charlie said, hundreds of thousands of Coloradans have medical debt, and research shows that hospitals are a big contributor to that problem. 3/4 of Americans who have medical debt are in debt to hospitals specifically. I think these statistics are pretty alarming, and they are a powerful indication that unaffordable hospital care is harming a lot of people in Colorado. So let's move to key idea number 3. Large hospital systems are making a lot of money in Colorado. Hospital profits are on the rise, and Colorado hospitals' profits are consistently higher than the national average. In fact, we in Colorado have the 4th highest hospital profits in the entire country. And that's in large part because Colorado patients are paying a lot for care. Hospital prices in Colorado are the 6th highest in the country, and that is not a distinction that we particularly want to have. Another indication that large hospital systems in Colorado are doing very well financially is how they pay their executives. We have data on CEO pay for these 4 nonprofit hospital systems in Colorado. Each of them is paid more than $2 million annually, And the CEO for Banner Health actually makes over $12 million a year, which I think is pretty astonishing for a nonprofit institution. I think it's important to note, though, as you can see in the bottom half of this graph here, is that hospitals' high profit margins are largely not felt by the people who are working hard on the ground, like housekeeping and custodial staff, receptionists, security guards, and nurses. Indeed, when you pay your executives exorbitant amounts, it leaves less money for other workers' wages, and it exacerbates income inequality in a state where those divides are already really significant. So let's put our big three ideas together here. Number one, we know hospitals have an articulated commitment and a legal commitment to serve their communities, including low-income people. Number two, we know many people in Colorado are struggling because of high hospital costs. And number three, we know Colorado's hospital systems are highly profitable. So to answer our question from up the top of whether Colorado hospitals can afford to do more for low-income Coloradans, I think the answer is yes, there is room for our hospitals to be more generous. So I want to pose the questions now to you all. What do we want to do with that information? Like, what opportunities do you see in your community to make hospital care work better for people? And what do you want to see happen next in this space? These are rhetorical questions. We have time for Q&A and discussion in a few minutes, and we're really eager to hear your thoughts. I look forward to hearing from you all. Thanks again for being here tonight. And I'm going to pass things over to Isabel Cruz from the Colorado Consumer Health Initiative to take us over our next content.
Thanks, Julia. Thanks, Charlie, for teeing up this important conversation about medical debt, high healthcare costs. So my name is Isabel Cruz. I am the policy director for the Colorado Consumer Health Initiative. I use she, her, hers, yeah pronouns. So us at CCHI, we are a statewide membership-based advocacy organization that seeks to ensure all Coloradans have equitable access to high quality, affordable healthcare. We're so proud to partner with CCLP and many other people in our state to make that a reality. So I'm excited to talk tonight about how can we think about some of these big thorny issues and some examples of turning problems into community-driven solutions. So with the big questions that Julia posed about what we can do regarding how hospitals can better serve people in the community, or these questions of how do we eliminate medical debt. As has been described, this is a big issue with many root causes that are interrelated, as well as impacts that are also interrelated, whether it's insurance coverage challenges, high cost of care, the financial toxicity of having medical debt, how that relates to these larger intersecting oppressions, can make this feel like a big hard conversation to have about what do we do to make sure Coloradans have equitable access to coverage and don't have any medical debt for seeking care. So we as advocates, and I say we as in everybody in this space, can think about what role we want to play in the range of tactics that we can take to make steps towards getting towards this big goal of eliminating medical debt. So we have to consider what the scope of what we want to tackle is, how big, how small, what resources and influence we have, and what routes we want to pick from. You can do anything as an advocate from the individual level all the way up to the systemic level. So an example of what that might look like on the individual level is, directly intervening in a case in which somebody has medical debt. That's what our consumer assistance program at CCHI helps people with on the ground, navigating their bills and trying to make sure that they can bring those costs down and afford their care. Some providers or hospital systems may choose to change some of their practices, lower costs or change the way that they provide charity care or bill in order to, eliminate or reduce medical debt in their practices. But also, if many people are having the same issue, what can we do at the systemic level through legislation and regulation to make the changes that we want to see? So in the policy world, we think about these opportunities to make change as windows of opportunity, right? When we see a problem like medical debt or any of the things that fall under it, there's political will, so decision makers and community cares about solving this problem, And we have a solution. We have an idea of how our systems can change in order to tackle one big part or the whole shebang of an issue. And so this is kind of how we have to conceptualize, if you're seeing an issue, how we solve it. So I'll give one example. So facility fees is an example of tackling one small piece of the rising hospital prices puzzle we've started to focus on today. So if you're wondering what a facility fee is, so they were originally really designed to compensate hospitals for standby capacity for their emergency departments and for complex care. But as hospitals have grown outside of their campus, a traditional campus, and have been either building or purchasing outpatient facilities like doctors' offices, we've seen facility fees being added to people's bills in arenas of care that weren't expected, right? Routine care, doctor's visits, et cetera. And so through our consumer assistance program, we worked with clients who were getting hundreds or even thousands of dollars added onto their bill. And while our navigators were working with the hospitals and with the patients to try and lower those costs, which were often very surprising or challenging for people to pay, we decided, in conjunction with people who've experienced these challenges, as well as coalition partners like CCLP, to create a systemic solution through legislative advocacy. So that's how we got to HB 23-1215. So it started off as a more robust approach to thinking about, these facility fees were originally supposed to be charged in certain arenas where complex care is delivered. How about we make care more understandable and affordable for people by eliminating where these are charged outside of the hospital campus? And we knew from polling that over 81% of Coloradans were in support of making this change. However, like anything that is important, it was tough to push this policy forward, particularly in the healthcare arena when we're dealing with really well-resourced industry players. And so through the really strong advocacy of our directly impacted consumers, our legislative champions, who were Representatives Sirota and Baisnecker and Senators Mullica and Cutter, we were able to pass a bill that will provide a pathway for a robust study of what facility fees do in our state and how they impact the cost and accessibility of care, as well as put some safeguards in effect starting in July of 2024. So there will be limits for patients to make sure that they're not getting billed directly for facility fees for preventive services. So these are like your annual checkup, your vaccines, right? Things that are supposed to be free under the Affordable Care Act, and making sure that that promise is real on the ground for people, as well as making sure that there's transparency in both English and Spanish for people who are walking into a facility that can charge a facility fee, as well as at the time of appointment and when somebody's doctor's office changes hands. So this is one example of how identifying a problem, working on the ground with community to develop a solution, and pushing something forward can look in real time, in addition to some of the great policies that Julia and Charlie were talking about earlier. So the question I'll leave you with, and I'm excited to talk through in this in the participation portion of the forum, is what in your life and in your community is an issue that you want to leverage our collective power as advocates to transform healthcare. Even though it's hard, even though it may take many times, we are the answer. People on the ground are the answer, particularly people who have been systematically excluded in our healthcare system. And so just want to pose some ways that people can really get engaged. You can elevate your issue, share your story so people understand what you've been through, and also so that other people who have experienced what you have can join in the fight and know they're not alone as well. You can help design and fight for policies that you believe in, and spread awareness of existing rights and protections, because things are only as valuable as how aware people are of them and how well they're working on the ground. And repeat. I won't pretend that this is a linear process or that this is an easier process, but I'm excited to hear from you all what role you want to play in making our healthcare system more equitable and affordable, and in eliminating medical debt. So excited for that portion of our conversation.
Thank you so much, Isabel. Thanks for that call to action. It's inspiring. Charlie and Julia, thank you so much for the insight and commentary you have provided on this important issue. We're going to switch. So for all of you who are in the audience, please do keep in mind your questions, thoughts, responding to Isabel's call to action of speaking your experience and what changes would make a difference in your life or for your community, and hold those tight, because at the end for the Q&A, we want to hear them. Right now, we're going to switch to part 2 of the presentation, which is switching to healthcare disparities in Medicaid. So this is focusing on access to care, access to public health benefits, access to public health programs, and the way that we can do that in an equitable way that really centers people's humanity. And to kick that off, I'm going to introduce Bethany Prey, our Senior Legal Director at CCLP. Bethany.
Thanks so much, Lydia. I'm Bethany Prey. I use she, her pronouns, and I'm the legal director here. Going to our first slide. So how can we improve equity in Medicaid while addressing the quality of care, and really why is that so important? Expanding access to public health programs like Health First Colorado, our state Medicaid program, is one way to tackle prices and debt and reduce the resulting inequities. Medicaid covers more Coloradans, right now about 1.5 million, than any other single coverage entity in the state. It covers treatment for behavioral health and for physical health. It's unique in its ability to cover services for people with disabilities so that they can live and work in the community. And it's the primary payer of nursing home costs for those who can't manage in community settings. Nationally, 2/3 of adults have had some connection with Medicaid themselves or through family related to pregnancy, birth, home health, or nursing home care. To improve equity, Colorado's Medicaid program needs to ensure that every person has the chance to attain their full health potential. Social position and socially determined circumstances should not get in the way of that, whether we're talking sex, gender identity and expression, ethnicity, disability, language, immigration status, language, age, or sexual orientation. Our state Medicaid agency, the Department of Healthcare Policy and Financing, sometimes called HCPF, published a report on equity entitled Closing the Gap in 2022, and the State Health Equity Task Force continues to grapple in bi-monthly meetings with how to identify and address current disparities. It's hard to overstate the potential impact of improvements to quality and equity in Medicaid on the overall well-being of the state. So one of the first steps is to use and require better data. We first have to know who's able to access services and who is not, and know how health outcomes differ, and for that we need good data. As a state, we're not there yet. Based on reports from federal partners, Colorado has failed to provide timely and accurate demographic data to federal agencies. However, in the past couple of years, I've also watched while state staff has demonstrated an increasing ability to provide detailed demographic data that has helped provide some amazing insights into disparities in access to behavioral health care, prenatal care, and other types of services. And that's really important progress. Qualitative data that captures how people view their experience in Medicaid is equally important. Like most states, Colorado uses standardized surveys, known as the CAP survey, that ask members about their care. But results are reported in a form that is hard to find and hard to read. We've heard that people who contribute to the survey, but who then don't see the final report and don't see their experience in Medicaid changing, may not bother to contribute in the future. Sharing information in a user-friendly format should be a standard practice for HCPF and other state agencies. The most recent survey results show that member experience with our regional managed care entities, known as the RAIs, compares unfavorably with the experience of Medicaid members in other states. In the graph on the left, a 1-star rating means our managed care entities as a whole are in the bottom quarter nationally for the factor in question, and 2 stars puts us in the bottom half nationally. There are a lot of 1 and 2 stars in this compilation. The 2022 survey tells us that 2 key drivers of Colorado's low ratings are the difficulty of getting care when needed and a doctor failing to show respect for what the patient said. Those 2 measures really go to the heart of what equity or inequity means. So what are our solutions? And we would say centering member voice, enrollee voice. As we look at the next phase for those regional accountable entities, the RAIs, we know that the status quo won't do, and member experience should be foremost in our minds. Community members have unique insights into the obstacles they encounter in Medicaid and other public programs, and when they engage in policy, they bring insights that go far beyond what can be captured in a survey. There's also been progress in this area in Colorado due both to federal rule changes, and even more to community advocacy. Now, for example, a 2021 bill that brought a series of reforms to our state's cash assistance program also created a member council. And then in Medicaid, through rulemaking, the state created a maternity advisory council that is primarily people of color to advise on Medicaid policies around pregnancy, birth, and postpartum care. And that's an area where we've seen some pretty steep disparities. We have a well-run member engagement advisory committee at our state Medicaid agency, smaller committees at each of the RAIs, and in other committees, it has become more common to set aside particular seats for enrollees or their families. The next step is to ensure that the problems they identify and the recommendations they make are public, are posted, and ensure that policies and funding follow those recommendations. We're going to delve in for a few minutes on care coordination and case management, which are functions that specifically prioritize a member's needs and where a person's perspective should drive the results. When someone can be engaged in directing their own care, and when their particular hurdles can be addressed, that's equity in action. Last year, our state Medicaid agency issued a report on health equity and identified as a critical outcome, quote, to develop and identify ways to actualize coordinated care for person-centered outcomes. We agree. My colleague Melina will be talking today about why those functions are so critical to getting quality care and addressing inequities. And now to Melina Castaneda, my colleague.
Hi, thanks, Bethany. My name is Melina Castaneda, and I use she, her pronouns, and I am a policy fellow here at CCLP. Prior to my time here, I provided direct care as a case manager in an outpatient behavioral health setting. Clients who were transitioning out of an inpatient behavioral health stay, had a recent suicide attempt, or were getting out of jail were assigned to case management. Prior to the pandemic, I had a manageable caseload and was able to provide excellent care coordination. I was able to meet with clients with complex needs multiple times a week, and new clients didn't have to wait more than a few days to schedule with me. As you can see from this image, we spent time filling out job applications, housing, motel and bus vouchers, applying for Medicaid, calling and scheduling any additional appointments, and ongoing crisis management. Those that needed more appointments and hands-on work were within populations experiencing significant health disparities. An example of this was when I worked with a homeless mother. She had her children living with their father as she continued to live in her vehicle. I helped her obtain employment and moved our appointments into her lunch hour. I needed to show respect for the progress she had made and accommodate her schedule. During those lunch hours, we worked on applications for Medicaid, housing, and additional support systems. As a case manager or care coordinator, you have to take a step back. Understand that you may be the first person this individual has spoken to about what may have been a life-changing event or a recent mental health crisis, and be open-minded about their life experiences and where they are in their ability to achieve services. My work focused on working with the client to identify obstacles to get care and helping to remove them. Many of these obstacles fall in the category of social determinants of health. Lack of housing, income, and food were huge obstacles for the client who was living in her car and stood in the way of her achieving better health. Others had informational barriers. They didn't know what was available, or they needed help navigating applications and had difficulty sharing information due to the stigma. I often went into the community to meet my clients for their appointments when they were unable to come to our clinic because transportation was another one of their primary hurdles. One client had missed many appointments at the clinic's office with prior case managers, and I instead was able to set up appointments with my client at her home. I would show up with a plan for us to work on, but she was often in crisis, and I found that by sitting with her, listening, being present, even helping her around the house with chores, we were able to work towards stabilization. At the end, I was able to help her get onto housing voucher lists, obtain Social Security disability income and Medicare, maintain her Medicaid and SNAP benefits, and supply her with coping skills. One additional piece I want to emphasize is the importance of interacting with people in a format that works for them. While telehealth may seem to be a way to remove some hurdles, it can add others. Not everyone has a smartphone, is technology literate, has internet, or even wants to talk about their situation over the phone or on screen. The client I just described could only do phone calls when she had minutes. Even when she did have minutes, using those for telehealth meant she had less phone access for other purposes. For her, the in-person contact was essential. If caseloads are small enough to allow for direct contact and relationship building, case management and care coordinations are functions of the Medicaid system that can very effectively identify and address disparities. And I'll hand it back over to Bethany.
Thank you, Melina. So Medicaid, just in closing out, Medicaid is a great program. It has a lot going for it with comprehensive benefits and minimal costs. But if access to services is hampered and the needs of users are not recognized or prioritized, we're losing an enormous opportunity to reduce disparities. Many deficits have been known for years. Low rates of prenatal engagement, many children missing their well child checks, poor follow-up rates after behavioral health hospitalizations. Colorado's spending in Medicaid tracks with those below average results. In terms of our state economy, we may be a wealthy state, but our expenditures are around the 45th percentile nationally. Beyond acknowledging the data we already have, moving toward a more equitable system requires that people who utilize Medicaid are given the opportunity to lead, that the rest of us listen and learn from them, and that dollars follow the priorities that are identified. The next rendition of the state's managed care system, the RAISE, is in development, and a new structure will be in place in July 2025. Requirements for data collection, for ongoing opportunities for members to contribute, for more meaningful care coordination and case management should all be part of that new plan. We hope you'll all be weighing in on the state's proposal and the coming contracts, as well as thinking about ways generally to put community members first in the coming legislative session. Thank you. And back to Lydia.
Thank you so much, Bethany and Melina. That gave us a lot to chew on and hopefully inspired some questions and comments from the crowd. So this is our opportunity to really become a forum of a whole and to have a conversation around the questions that you have, your personal experiences that you'd like to share. I see there's one question right now in the Q&A box, which I can jump on. And Bruce, let me know when someone is raising their hand and you're ready to take them off mute. So I'll just start with this first question. And Charlie, I believe that this one heads over to you. Does House Bill 1126 apply to medical bills from out-of-state healthcare providers?
Thanks for that question. House Bill 1126 applies to all Colorado residents, regardless of what state the debt was incurred in or what state the credit report is being pulled. So it is Colorado residents. If you are legally a Colorado resident, you are covered under this bill.
Thank you for that, Charlie. Bruce, do we have anyone from the audience? I see Bruce is posting. Go ahead and hit raise hand if you'd like to come off mute.
Yeah, if you'd like to come off mute, go ahead and choose the raise hand button at the bottom of your screen, and we can unmute you if you want to speak directly. But at this time, we don't have anybody raising their hand, so you can proceed to some of the questions that we've assembled on the document if you like, Lydia.
Sure. So, question for the panel. How do we balance the push for bold efforts to reduce medical cost burdens while also taking into account the political environments and repercussions? So how do we balance the things that we really would like to get done with the things we think we can get done? Who wants to jump in? Is it an unanswerable question?
I can go ahead and start and then see if other folks have additional reflections to share. And I will say that I think Isabel did a nice job of sort of setting up some of the groundwork for how we make some of those calculations. One thing that we often think about and talk about at CCLP is we use the language of like a North Star. Like, what is it that we are really trying to push for? If we can wave our magic wand, what does the world or what does the Colorado we want to live in look like? And let's think aspirationally about really what we're after. I think oftentimes it's easy to get sort of bogged down in the weeds and think sort of what's attainable for the 2024 legislative session or what have you, which I think is important to be pragmatic. And when we are so narrowed down on those shorter time horizons, it can be easier, or one can tend to limit oneself to more incremental change. I think incremental legislative efforts and advocacy efforts generally absolutely have value and are often strategic, but we want to make sure that we are ultimately working towards sort of overarching North Stars type goals and are doing so in community, in partnership and coalition with our fabulous partners.
Thanks, Julia. Appreciate that balance. Anyone else on the team want to chime in? If not,
I guess I'll add,
go ahead, Bethany.
building on what Julia said, that a lot of efforts take a lot of time, right? So it may be that there's a goal that will take a few sessions to reach, but it's during that time is the engagement with community to really establish the right way to solve those problems, and that really does take time, and it takes a lot of input from a lot of people. So I think it's the political situation will change during that time, while the community is figuring out what they really want to see in the solution, and so that time is sometimes a gift.
That makes sense. We do have a question from the audience. Teresa, if you'd like to come off mute and share your question or comment.
Thank you. I also put it in the Q&A, but I am working in my local community with a team of folks to better understand community benefit in the two local hospitals, particularly because the hospitals are retaining more and more money in uncompensated care in the same period of time that we've brought our uninsured rates down from like 27% to 7%. And at the same time, when 15% of our county is in collections for medical debt. And so as I work with and some of those folks in the community are on this call. So what advice do you have for us as we attempt to work with the hospital to ensure, number one, that they are adequately surveying our community about their needs and not just using Facebook polls or other things that don't go very deeply into our community? And how do we better understand how to encourage them to prioritize things that the community really feels are priorities for the small amount of that community benefit money that does get presently reinvested in our community?
That's a great question. Thank you for sharing it. Who on the panel would like to jump in?
I can start us off. Teresa, thanks so much for that question and for your advocacy and the advocacy of your members on community benefit. I think the first thing that I'm thinking of relates to a policy that was passed last year around some of the processes of community benefit. I think we've heard from a lot of people across the state that some hospitals are doing community benefit engagement and needs assessment and following through on what the community is asking for them better than other hospitals. So the Department of Healthcare Policy and Financing has been tasked with moving forward a process to ensure that there's greater community accountability. So if you're asking your hospital, how can we address medical debt? If you're asking your hospital for all of these things that you all are elevating so well, that they then would have to be more accountable to you in this process. So there's going to be kind of like a stakeholder process. I would really encourage you all to share kind of what's been going well, what hasn't been going well, because that's going to inform the accountability process for the state and how they're going to hold the hospital to what you're asking them for, as well as there's going to be kind of a stricter understanding that in some of these community benefit report out meetings that the hospitals are required to do, that they have to share how they're putting their money where their mouth is. So not just we're investing in XYZ thing, this is what's going behind that, and making sure that that aligns with your expectations. So that's kind of a longer term strategy. I think you all are doing a lot of amazing things, but I think the Healthcare Policy and Financing has been tasked with playing a stronger role in creating accountability in these processes, and would benefit from all of you helping strengthen that process to the best extent possible.
Great. We look forward to doing that.
I wanted to add, if I can, Teresa, I really appreciate the great work. I think also just from CCLP's experience that there's, sometimes one tool is really effective, like direct conversations. Sometimes there's another tool, and that's, Isabel's suggestion about talking to the Healthcare Policy and Financing is because they have different tools that they can bring to bear. And then there may be other groups out there, CCHI, CCLP, others who will say, there's even more that we've thought about that might help advance your effort. So I think sharing the information that you're learning and collaborating with more groups is really valuable.
Great.
Thanks
Thank
so
you
much for the question, Teresa. We have some questions in chat. Andrew West asked, I know we were expecting some pushback to 1126, possibly a legal challenge. Are there similar concerns about the nationwide policy? Or does the CFPB have the authority to make this rule without any hiccups? And Andrew, feel free to raise your hand if you want to add anything to that question or do a follow-up from the panel. Julia, I'm going to kick this one over to you.
I am so sorry. My audio is cutting in and out a little bit, and I'm not joining from my normal desk today. Lydia, can you say that again for me one more time?
Sure. It's also in the Q&A if you read this. It's Andrew West's question. The question is around pushback to 1126. Do we have any concerns that the CFPB will be able to make this decision and not get any pushback or hiccups in implementation? Do they have the authority to do that without the kind of pushback that we might expect at the state level?
Beautiful. Thank you for restating. Thank you, Andrew, for that excellent question. So yes, there's sort of like two pieces here. One is when states pass legislation, there are sometimes entities that wish that had not occurred or have legitimate legal concerns around sort of one's authority to do that. We see that show up at the state level and at the federal level, particularly more currently around the Consumer Financial Protection Bureau, which is an entity that is tasked with keeping consumers' financial world safe and well-regulated. To Andrew's specific question, the CFPB, I think, my assessment as a non-attorney here, absolutely has the authority to proceed with the rulemaking process that they recently announced and that Charlie alluded to create rules that apply across the country to keep medical debt off consumer credit reports, just like we just passed in Colorado. And the Consumer Financial Protection Bureau and the Biden administration generally have a lot of lawyers on their staff, who I imagine are very good at their jobs and believe in that authority as well. That said, the development last week is not that this is now the law of the land in the United States. It's that the Biden administration is making moves to enact these rules. That means there's still a bit of a road ahead, and there may be some political barriers and legal challenges that sort of lie ahead in the coming weeks and months. months. So what that means for us as consumer advocates on the ground at CCLP and for many of our partners as well, is we want to keep an eye on that process. We want to watch for opportunities for consumers, patients on the ground, and consumer advocates to weigh in and help describe the value that we've seen in this policy here in Colorado and help smooth the passage of those rules at the federal level. So I would say, short version, watch this space. We're really excited about this progress. I think I feel cautiously optimistic about the path forward, and I think it's absolutely appropriate to stay vigilant about sort of any possible threats that might be waiting in the wings.
Thanks, Julie. Appreciate that. And I saw the chat with Teresa asking Isabel and Julia if they could, and Bethany, to reach out later. We will have a final slide with contact information for following up, so that will be shared with everyone at the end. A comment, but not a question, from an anonymous attendee. We need a fair way to assess and compare how hospitals are reinvesting their profits, whether in services that will make more profits and market power or in ways that truly meet community need. So similar conversation around what is community benefit and how do we invest in it, and where do hospital profits go back into either business services care or into the community. Another question from Catherine. Could someone talk about Medicaid redeterminations? I know that's not part of this presentation. That's totally fine, Catherine. But what are organizations doing to help people keep coverage? Bethany, I'm thinking that's you.
Sure, I can talk a little about that. So, there are a lot of efforts in the state to work on keeping people covered. CCLP is working with several different groups, both a set of disability advocates, as well as covering kids and families, which is part of the community health network, to convene both people that help enroll folks in coverage, as well as people with disabilities, to figure out what's happening on the ground and what we can do to advocate with the state agency for changes. So there is a lot that's underway, and we would, I'm not sure if this was the implication of your question, but we do feel like there are a lot of issues out there. The rate of disenrollment is very high. There are a lot of procedural disenrollments. That means that someone has been disenrolled because the state says it doesn't have the information it needs to make a decision. So there's a lot going on there, and we'd love to talk more about it. I know this definitely affects our providers, hospitals, clinics, and so we'd like to talk more.
Thanks, Bethany. Anyone else on the panel want to chime in? That was a pretty thorough answer. Another question in the chat from our own Shar. With the various policy changes, who is most likely to be uninsured in Colorado now?
I think I'm gonna just give a starter of an answer, and I'm sure Julia has more to say on top of this, but we do know that young people are by and large more likely to be uninsured than other groups of people. Also, BIPOC individuals, LGBTQ people are also disproportionately more likely. However, youth have a greater effect of being uninsured.
Yeah, appreciate that, Charlie. I would just add, that we know communities of color and particularly immigrant communities face a lot of unique barriers to accessing health insurance coverage, both public coverage programs like Medicaid, or help paying for private, I should say, the word I'm using is subsidies, help paying for your health insurance costs through the marketplace, as well as challenges accessing private insurance generally. And I think Colorado has done a lot of fabulous work reducing some of those barriers for immigrant communities, DACA recipients, and undocumented folks in particular, but those remain really substantial systemic issues. Another thing I would mention, I guess, is that following the Affordable Care Act in states like Colorado that have adopted Medicaid expansion, we've seen a reduction of Medicaid expansion and a number of other different pieces. We've seen a substantial decline in our uninsured population in the United States and in Colorado specifically, which is really exciting progress to see. And so with that, my perception is that we need to continue to have these really important conversations about how to continue to shrink that uninsured population. No one in the United States, regardless of immigration status or citizenship status, should be uninsured. And how do we think about those among us who have health insurance? How do we ensure that health insurance is genuinely quality, genuinely affordable, genuinely provides protections for needed healthcare, dental care, vision care, and so on?
Thanks, Charlie and Julia. Another question in the Q&A from Amy. How can we ensure the new care management agency case managers receive the training to provide appropriate, culturally sensitive support? Many of the CMAs exclusively serve CCBs and now serve clients in long-term care on conditions they have little training to support. Also, how can we ensure rural hospitals have the funding they need while requiring the larger hospitals to do more? So that's kind of a two-part question. If y'all need to read it, it's also in the Q&A.
Those are really big questions. And so I'm gonna start and tackle the first one about case management and cultural competence. I personally don't think that we spend the kind of money that we need to spend on case management, care coordination, to make sure that we have people who are trained, to make sure that we are providing additional incentives for people who are bilingual and bicultural to provide services. That was actually a topic at the Health Equity Task Force last week. How we can get more people who bring that lived experience, language experience, and cultural experience to the care coordination and case management roles. I think that's really important, but it does mean additional funding. And so we have to prioritize that. Anyone else want to, I don't know, Melina, if you want to add to that, because I think a lot of what Melina illustrated is when someone is spending adequate time and effort with a patient, they can really make a big difference. Go ahead, Melina, though, if you have more to say.
Yeah, I think one thing I would really add is the focus on caseloads, because the higher caseload, the less time you have to spend with your clients. From my experience, when I had a really low caseload, I was able to meet with each person individually, really spend that full hour with them that we would schedule and hit all the nitty-gritty issues that they were having. Towards the end of my time as a case manager, my caseload doubled, if not tripled. And I was unable to help those people. People weren't able to see me for 2 months out sometimes. That's how far scheduled out I was. And not giving the people the attention they need is providing a disservice. And this is something that they really need to look into and put the money where it needs to be, which is hiring more people for less caseloads, so that the people who have long-term care needs or more complex case needs have the time and attention they deserve.
Thank you both for that. And Amy, I know that was a long question and lots of answers. Feel free to raise your hand if you wanted to add a question or had a follow-up to that answer. Okay, I'm going to head over to another question for you all to consider. What do you view as the biggest obstacle or a big obstacle still facing low-income folks in accessing healthcare? You've covered a lot of the changes. What do you think is the biggest nut to crack?
This is definitely in the North Star category, but the complexity of our healthcare system is probably the biggest obstacle. As people's income changes, as their circumstances change, they have to figure out what the next possible coverage entity is. Coverage is at most a year at a time. In commercial coverage, it's really only a month at a time in Medicaid, because changes in income can knock you off coverage. So those burdens on individuals, I think, are one of the biggest problems. But I welcome others on the panel say more.
Thanks.
This is
Stephanie.
not a comprehensive answer, but one short answer, and one that maybe is a common refrain, is here in Colorado, we have something called TABOR that limits our state's ability to pull in public funds and retain those funds for public services, public programming, other types of investments that state governments and other states are empowered to strengthen. And so we have that authority too in Colorado, but it can be challenging when there are just not enough dollars to meet all of the needs that are out there. And so thinking about how we finance public services in the United States and in Colorado in particular, looking really closely at taxes specifically, and how we allocate those funds, I think, is a sort of less sexy piece of the puzzle than thinking about sort of the site of care, but is important sort of piece of context when we think about what's attainable here on the ground.
Thanks, Julia. Also want to call out Teresa's comment of one of the biggest barriers being fear of cost. So Teresa, I'm interpreting that to mean people aren't accessing the care they need because they're afraid of the cost, which has its own repercussions. So thanks for sharing that. And go ahead. Yeah, please unmute.
Yes, I think I think for lots of folks, they don't go to even the emergency room until they're doing pretty poorly, mainly because they don't feel like they're going to be able to navigate the system, but more importantly, they don't feel like they're going to be able to literally pay the price.
Right.
Yeah, I just want to echo that too. That was the really first thing that came to mind for me as well, even though there's a million things obviously that I think are a challenge. But I think that there are so many disparities in who is avoiding care for costs, but the majority of people are avoiding care for cost, for fear of cost. And, that's true for folks who are on Medicaid, which is one of the highest value types of coverage that you can have. It's creating some of these vicious cycles of when people are not accessing the care that they need earlier on, and it becoming more serious and affecting people's quality of life and driving up the cost of care. In the Colorado Latino policy agenda, they did a really great survey that really dug into healthcare costs. And for folks who had said that they avoided getting care because of costs, the 40% of those folks said it was primary care, right? So care that's supposed to be more affordable, care that's supposed to prevent some of these harder things to go through for people. And so I think that fear of costs and bringing down costs is really at the crux of making sure people don't feel like they have to avoid our healthcare system at all costs.
God, yes, 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 Isabel, what an excellent response.
Thank you, Isabel.
And I was going to add, if I could, that I think that kind of concern is one of the reasons that the Colorado option plan, that was very stakeholder driven, is one that prioritizes primary care and behavioral health costs so that people can access more care before they have to think about their deductible, if you can get coverage.
Mm-hmm. That insight is echoed by Amy, who shared the lack of continuity of care for people for mental health or behavioral health due to either lack of providers or lower reimbursement, which causes lack of providers, is a real challenge for people getting quality care right now. We have another question in the chat from anonymous attendee. As we continue to put pressure on hospitals to reduce costs, how can we ensure that they don't respond to these policies by reducing quality and access for lower income staff and patients?
I appreciate the question. I can start and then pass to some colleagues. So I will start by saying it is, we just celebrated the 1-year birthday of some new exciting patient protections here in Colorado. For folks who are familiar with hospital discounted care, this is a new set of protections around what financial assistance has to look like for low-income hospital patients in the state of Colorado. So previously, we had some guidance on the books around hospitals' obligation to provide financial assistance to uninsured patients and or low-income patients. But as of this past year, we have a lot stronger legal specificity around who needs to receive that assistance, i.e. all low-income folks in the state, regardless of immigration status, regardless of citizenship status, regardless of insurance status. And we have a much clearer requirements, clearer guidelines around what that financial assistance needs to look like. Part of that law also says hospitals are not permitted under the law to turn patients away because they have an outstanding medical bill, because they're low income, because they're someone who's low income enough to be eligible for financial assistance. And so I think this question is an excellent one and a good indication of why these types of protections are useful for patients, because we really want to protect against those unintended consequences. The other thing I'll say is that we know that not all hospitals in Colorado are the same. And so moving forward with policies that are responsive to differences across rural Colorado and urban Colorado, across large profitable hospital systems and smaller, more independent hospital systems is absolutely something that we know is important to the landscape. It's important to patients, it's important to policymakers, and it's absolutely something that we want to stakehold thoughtfully and be responsive to.
Thanks for that, Julie. Appreciate it. Does anyone else want to respond to that question?
I'll just chime in briefly. I think you covered it really well, Julia. And I want to acknowledge, right, that these are kinds of threats and talking points that are thrown around in these conversations, right? That cuts to, these really high costs that we're seeing have to come at the expense of low-income patients and of staff who are paid less. And that to me is an unacceptable way of dealing with this healthcare affordability crisis. And that is something that as an advocacy community, we have to continue holding hospitals accountable for, especially ones that in their founding documents say that they are there to serve indigent patients, right? Like that is just in so many of their founding documents, right? And so I want to acknowledge that that's a real fear and something that is a real part of the conversation. But we also know that the status quo is not serving frontline workers and patients on the ground, particularly low-income patients, well either. We're seeing hospital systems expansions, not necessarily into all of the areas that are most serving people, Medicaid patients or folks who are the lowest income. We are seeing, right, medical debt only increasing and increasing, even though the ACA and other things are bringing more people into insurance, like we've discussed, right? So I think that really holding firm to our values, as Julia was talking about, holding hospitals accountable to what they say they're doing and why they were founded and why many of them are nonprofits, is going to be an important part of making sure that we stay grounded and not putting our most vulnerable people on the chopping block first in these conversations.
Thanks, Isabel. Bethany and Melina, you both mentioned case management and care coordination in the information that you shared. Why do you think Colorado Medicaid has struggled to provide case management and care coordination that's really high quality?
Well, I think one issue is that our regional accountable entities are managed care entities that are responsible really for a lot of care coordination and case management. This is separate from what people with disabilities receive, different case management system. But for the managed care entities, they have many jobs to do. So many jobs to do that I think they're spread too thin. If it's really a priority for us as a state to do a better job at that, they may need to do fewer jobs and really double down on this one that connects people to the care that they specifically need, and can. I'm gonna pass it to Melina, because I think what that means again is something that you really only see working directly with people. Sending out like text reminders, that's not care coordination. from my point of view. It needs that really in person or direct contact.
Yeah, I would just add that we tend to see members, especially on Medicaid, as numbers rather than people. And we need to do more person-focused centered work. And that has really fallen off the edge, especially through the COVID pandemic, as we continue to highlight more telehealth options. Not everyone has the ability to have internet or a smartphone. So being able to receive those services are diminished by a lot of people who are unable to obtain those resources. So we really need to look at, see how can the raise go into the community more? How can they meet the people in their homes? How can they meet them next door at a Starbucks? Really meeting the people exactly where they're at, because you need to be there for them. They're not there for you. You're there for them.
Mm-hmm. Thanks for that reminder, Melina. And we only have a few more minutes left in the forum. So last call for questions, solutions, ideas, experiences that you want to share. I will ask, kind of following up on the end of Isabel's presentation, the panel in general, what are some upcoming advocacy opportunities that people could take advantage of to get involved in this issue?
We have so many. I was waiting for one of my colleagues to jump in. One set of advocacy opportunities involves what the new look of the regional accountable entities is going to be. So we're going to have a whole new structure beginning in 2025. But between now and then, there are a lot of opportunities to weigh in and make your voice heard about what you want them to be doing, how you want them to do it, how you want us to be prioritizing our dollars, how you want to make sure that they honor member voice and show their and continue to follow that as they operate. So there's a concept paper that's out now where the state is asking for comments that those are due at the end of this month. There's going to be more work in November. We can put the state page about this into the chat so that you can see those future opportunities. And you can also reach out to us if you want more details. But I'll pass it off to Isabel or Julia or others about other types of opportunities.
I would just add, so I mentioned that we just celebrated the first birthday of Colorado's new hospital discounted care law. And as part of our work at CCLP and CCHI, and with many of you all, we want to make sure that we're not just laser focused on bringing strong policy through the legislative process, crossing the finish line by passing the bill, and then walking away and turning to the next thing. We want to be really focused on making sure that legislation that we championed is working as intended and as well as possible for Coloradans on the ground. So a big part of that is getting the word out about what the new protections are. We did a lot of that, and we have resources on CCHI's website, which I'm happy to drop in the chat. Isabel spoke to that earlier, I think, the importance of public education. It's also important to enforce our legislation, enforce our consumer protections. And another piece is monitoring, getting a sense of how are things going on the ground, what's going really well, what's going poorly, who is falling through the cracks, and what advocacy opportunities are available to us to tighten up elements of the law that are not working as intended or are not working as well as they could be for Coloradans. So with that in mind, in the context of the new hospital discounted care law, we just hit our first birthday of those protections. We've had a year of this out in the world, and we're really interested to hear from patients on the ground and from folks who work directly with patients, who work directly with community. How is it going? What's going well? What's going poorly? So if you have a story to share, something that happened to you, your experience, your friend or family member's experience, something you're noticing with your clients, what have you, we would love to hear from you. My email is on this slide, and I'll drop it in the chat as well. And would invite any and all stories, experiences, intel from the ground on hospital discounted care in Colorado.
All right, well, thank you everyone for that wonderful presentation, those great questions, very insightful comments, and some powerful personal stories. I really appreciate everybody who joined us this evening and your time, taking your time away to share with us and be part of this conversation. It's a powerful moment for our policy work and our agenda, and we truly appreciate your participation. If there's someone you would like to share this presentation with, or the comment that you made, good news is we have been recording this event and we will post it on our YouTube channel after our expert communications team has a little bit of time to do some post-production editing. So keep an eye out for that. And for previous policy forums in this series, you can also find those on our YouTube channel. And there will probably be an event summary posted on our webpage as well. So we encourage you to go there and find a lot of great resources about what our presenters and panelists have talked about this evening. It's at cclponline.org. So make sure you check out those resources and further information to follow up on this great event. And I want to mention also that while we can't do this work without the partnership of everybody that you've heard from today, and without the great community that you're all a part of, and for your participation, we also can't do this work without the financial support of our funders and our donors here at CCLP as a nonprofit. So if you were moved by the powerful work that you heard about tonight and you want to donate, you can also do that on our website at cclponline.org. And we definitely encourage you to think about becoming a recurring monthly donor, which helps support our work all year long. So with that, I'm going to thank you all one last time for joining us this evening, and we are going to conclude this policy forum event. Thank you so much.